Hello students, I am Dr. Divya Krishnamoorthi, Associate Professor from the Department of Prosthodontics, Vinayaka Mission Shankaracharya Dental College. Today we will be discussing about FACEBOW. So the contents that we will be covering in today's class are the definition, the rationale for using FACEBOW, the indications and contraindications, the hinge axis, what are the anterior and posterior reference points, the history of FACEBOW, types and the parts of a FACEBOW, and a small summary. So let's move on to the definition. A FACEBOW can be defined as a caliper-like instrument which is used to record the spatial relationship of the maxillary arch to some anatomical reference point or points and then transfer this relationship to an articulator. It orients the dental cast in the same relationship to the opening axis of the articulator. Customarily, the anatomic reference points are the mandibular condyle transfer horizontal axis and one of the selected anterior reference points, which is also called the hinge axis. So what is the rationale of using a FACEBOW? The masticatory organism is the most complex motor system in the human body, which is maintained in a constant state of dynamic equilibrium. Mandible is the moving part of the oral system and performs a multitude of movements to accomplish this function. Our concern is how to maintain this harmony that the nature has provided us while restoring part or completely all the missing dentition. To do so, we need instruments that can simulate the mandibular movements outside of the mouth, and such a device is the articulator. Now, how do we record these movements in such a way so as to allow the articulator to replicate the movements? That data of programming the articulator to these movements are recorded from the patient through static recordings and dynamic recordings. The maxillary arch has a definite three-dimensional relationship to all the condylar movements. Static recordings allow us to pinpoint the location of maxilla, which is often referred to as the position of the skull, and the dynamic readings allow us to pinpoint all the movements of the mandible that may happen during chewing and during other physiological activities. FACEBOW serves to perform static readings which are fundamental to properly positioning the model within the articulator, or rather to replicate the exact location of the patient's maxilla. So the movement of the tooth or the teeth results in the rotation and sliding movement of the condyle. The better the cast on the articulator duplicating the distance to the rotational condylar centers, the less is the potential of errors that are produced by differences in the arc of closure of the mandible and the articulator itself. So broadly speaking, a FACEBOW will record in three planes: the anteroposterior, the lateral and the vertical, the position of the maxilla in relation to 2 points on the cranium, namely the glenoid fossa, and more specifically it relates the maxilla to the intercondylar line or the horizontal axis above which the opening movements of the mandible will take place. In normal subjects and for a small opening movement, the horizontal axis of rotation does in fact pass through the condyle. It is true that in wide opening movements, the axis becomes progressively displaced downwards, but this is of anatomical rather than prosthetic interest. It must be emphasized that in restorative and prosthetic treatment, we are concerned with relationship between the teeth and only when they are in occlusion and at most when they are slightly separated. The purpose of FACEBOW is to relate the functional relationship of the maxillary arch to the axis of rotation in the mandible and the aesthetic relationship of the maxillary arch to other skeletal landmarks on the head or the face, and then transfer this relationship to the articulator. So let us learn what is terminal hinge axis. This is the starting point to recording the position of maxilla in a static record. The terminal hinge position is the most retruded position of the condyle in the fossa. It is significant because it is a learnable, recordable and repeatable position that coincides with the position of centric relationship. In 1939, McCollum almost certainly discovered a method of locating hinge axis accurately, and together with Stewart, the development of an articulator to duplicate jaw movements and their invaluable research has led to the concept of gnathology. Snow recognized its importance and developed a FACEBOW to be used to transfer the position of the axis to the articulator. Before and since then, extensive research has been done on the existence, the recording and transferring of the hinge axis. Based on this, there have been many schools of thought. The four most important schools of thought are, the first ones are the ones who believe that there is a definite hinge axis and that it should be located as accurately as possible. The proponents of this are Sloan and Thompson. There is a second group which includes those who believe that an accurate location of the terminal hinge axis could be of some value, but do not believe that it is of enough value over an arbitrary location that can be found out easily, and it is not worth the effort of locating a accurate axis. Then there is a third group who believe it is impossible to locate the hinge axis position with accuracy, and there are many of this group who believe the transverse axis is theoretical but not practical at all. Then there is group 4, which includes those who believe in transographic theory. These are the follower of the theory who believe that there is a split axis which each condyle rotates independently of the other. So let us learn about some of the posterior reference points which will help us in locating the hinge axis itself. So some of the points have been shown in the table which is on the slide. The first author who gave the point was Geisy. He stated that the point is present on a line from the upper border of the tragus and the canthus of the eye. It lies 13 mm in front of the upper border of tragus. There are many more points given by various authors, such as the Breckstrom point, which is 10 mm in front and 1 mm below on a line present from the middle of the tragus to the ectocanthum. There is Beck's point, which lies 10 mm in front from the center of the ear and 7 mm below the Frankfurt's horizontal plane. There are many more points given by various authors, such as Dawson, who propagated the palpation of the condyle itself. So let us move on to few of the anterior reference points which are used in FACEBOW mounting. First is orbital, which is used by Hunter FACEBOW with the help of an orbital pointer. The second is orbital minus 7 mm. This plane represents the Frankfurt's horizontal plane. Then we have Nasion, which is represented as point B in the picture. It is used with quick mount FACEBOW. Then we have the ala of the nose, which is designated as D in the picture. This plane represents the chamfer's plane. Then we have 43 mm superior from the lower border of the upper lip or the lateral incisor. Lastly, the incisal edge with the help of the articulator's midpoint can also be used as an anterior reference plane. These various anterior reference points of orientation can either raise or lower the anterior part of the face bow not more than 16 mm. This lowering or raising of the face bow mounting does not actually affect the centric occlusion. However, it does have an effect on the acentric condylar readings which influence the cuspal inclination. For example, as the plane of occlusion is elevated, the condylar readings decrease. Conversely, as the occlusal plane is lowered, the condylar readings will increase. So, what are the indications of using a face bow? A face bow should definitely be used when we are planning to use cusp form teeth in balanced occlusion or while giving balanced occlusion in eccentric positions, and when we use definite cusp fossa or cusp tip to cusp incline relationship, or when it is required for us to use interocclusal records, or when a change in vertical dimension in the patient is desired. Now we will learn about the history of face bow. How did it come into existence and what are the various versions of face bow that has led to the face bow that we use today. In June of 1866, Francis H. Baldwin made a historic presentation to the Odontological Society of Great Britain. He believed it was impractical to measure the angle of condylar inclination in living subjects. So, he introduced an instrument for measuring the angle formed between the plane of two lines drawn from the articulating surfaces of the condyle to that of the occlusal plane, which is nearly good enough to use. He estimated that this angle, now known as the Barkwell's angle, to be an average of 26 degrees. He also revealed that he had constructed a bite frame by means of which we can use to mount the lower model in the same position in the articulator so as to have a relatively same relationship of the model to the hinge axis. Then in 1889, Richmond S. Hayes patented the first articulated with descending condylar pathways. In the same year, Hayes also introduced the first example of a functional face bow like device intended for locating the position of the cast correctly on his articulator. He named this device as the articulating caliper. Though it did not enable a fixed transfer or a three-dimensional orientation of the cast to the articulator, its only purpose was to record the distance from the patient's condyle to a point along the midline on the maxillary occlusal rim. In 1889, Professor Henry P. reported his investigations on mandibular movements. He was probably the first to use mandibular face bow to reproduce the movements of mandible and trace the individual pathways. He recorded 3 points: the condyle, the angle, and the symphysis by placing highly polished silver beads. The results were corroborated by previous studies that showed that the mandibular moved downwards, forward, and in addition he found that condylar paths were curved and that there was considerable individual variation in relative movement of the condyle, the angle, and the symphysis. In 1894, George K. Bagby of Newburn obtained a patent for improvement of an articulator of usual construction. He described it as an attachment to determine the location of impression models in the articulator and one that gives an exact measurement desired of the lower jaw when the central incisors are present. Bagby identified that one of the cheeks of the condyle as the posterior reference point. He also mentioned that alveolar border of the symphysis or the midline of the wax occlusal rim to be used as the anterior reference point for the jaw gauge that he had produced and patented. In 1896, William E. Walker produced the first adjustable condylar articulator. This instrument featured adjustable controls for recording variability of the downward as well as the forward movement of individual condyles and controls for variable lateral and vertical rotational centers. He called this instrument his physiological articulator. Walker was not concerned with reproducing the exact anatomy or the curvature of the condylar pathway, but only the angles of the pathway that were formed with the facial line and the alveolar or the alveolar pathways itself. This was the first instrument devised to determine the individual relationship and movement of the mandible for the purpose of constructing mechanisms or imitating these movements, and this was called as the facial clinometer. Though it was a very complicated device and it was not used very popularly. In 1899, George B. Snow introduced the first instrument and technique for recording the anatomical relationship of maxilla to the condylar axis and transferring this relationship to the articulator. Snow's new innovation were that the FACEBOW fork for identifying the anatomical position of the maxilla to the condyle, and secondly, the application of the ala tragus line for establishing the orientation of the occlusal plane. Snow adopted the plane of orientation suggested by Bromwell, that is the center of the glenoid fossa to the anterior nasal spine. Snow used the term ala tragus line, adapting it to the soft tissue structures for clinical application. He also introduced a basic FACEBOW in 1899, and it remains the prototype for all other FACEBOWs and the inventors that followed till this day. In 1902, John P. Parfett of Reading, England presented a paper to the Odontological Society of Great Britain and introduced his anatomical articulator called as the model jaw, because it may be made to reproduce to scale the movement of the mastication of jaws of any living subjects, he suggested. Parfett also introduced two mandibular FACEBOWs, one to transfer the cast to the articulator and one to transfer a record of the contours of the condylar path to the articulator. In 1905, George C. Campion introduced an adjustable graphic FACEBOW. He contended that no articulator could be truly anatomical unless it could imitate the exact condylar paths of each individual patient. Campion designed an adjustable FACEBOW fixed to the mandibular teeth with modeling plastic to graphically record the various positions of condyle on the face with a suspension of dots. Using white blotting paper, the dots, which were made of thick oil-based dye, were related to the ala tragus line with one edge on the paper and lifted off and transferred directly to either a paper recording or a glass lantern slide. In 1908, Norman G. Bennett of London presented a paper on mandibular movement to the Royal Society in London, and Bennett described an apparatus which was like FACEBOW and had two very small light bulbs attached to them on opposite sides, on the right and the left condyle and in the symphysis region. With the FACEBOW in place, the head of the patient was stabilized and the movements were recorded onto a wall and magnified, and this recorded the pathway of the mandible, and the same could be traced onto a paper and used to transfer this information onto an articulator. In 1910, Alfred Geisy introduced the condylar register. Geisy was not the first to determine the individual condylar path for articular use, but he began to improve and refine the process for clinical purpose. He was the first, however, to register the path for incisal points in the horizontal plane. He referred to the combined anterior lateral tracing as Gothic arch. He was also the first to measure the lateral condylar path and to incorporate this feature into the articulator. In 1921, Wordsworth added a new dimension to the face bow by providing a third point of reference through a T attachment and introduced it in his articulator in 1921. The anterior reference point was based on Wordsworth's naso-optical condylar triangle, which is shown in the picture. In late 1920s, another third point of reference, the infraorbital pointer, was introduced. Although the origin of this is unknown, it was immediately adopted by the Hanau and the Dentatus companies. In 1927, 3-piece adjustable face bows were introduced. Now let's see what are the different types of face bows which are available. Broadly, all face bows can be categorized as either arbitrary type or kinematic type based on what reference points they are using. The arbitrary face bows can further be divided into earpiece or fascia type of face bows, and the kinematic face bow can be divided into TMJ, axiograph and pantograph type of face bows. The arbitrary face bow relates the approximate condylar axis to the jaw in centric relation. The fascia type uses the posterior reference points to seat the condylar rod onto the skin. This is the main difference between the two types of arbitrary type of face bow. The ear type face bow has ear plugs which fit into the external auditory meatus and act as the posterior reference point. It is 6 to 6.5 mm posterior and 2.5 mm superior to the actual hinge axis which is present. The ear plugs are fitted into the auditory pin on the articulator, which has the same dimensional relationship to the axis of the articulator as existing between the hinge and the external auditory meatus. So what is the rationale of using an arbitrary type of face bow? Most face bow transfers use an average hinge axis location by referencing an approximation using the patient's ear. Research has shown that approximately 75% of ear bow transfers are within 5 mm of the true axis, which will create a minimum error at the molars. This average is within an acceptable range for most procedures when minimum to moderate changes are necessary in the dentition. However, there are greater concerns when extensive changes are to be made to the dentition or the occlusal vertical dimension needs to be altered. So let us see what are the parts of a face bow. So you can see first there is a bow, because of which the name face bow. Then there are transfer clamps which are used to transfer the data from the patient to the articulator. Then there are anterior reference point indicators and there is a bite fork present. Let us also see what is a kinematic face bow. So a kinematic face bow locates the rotational points by attaching to the mandible. As the patient opens and closes his mouth, a pointer is adjusted until the axis of rotation is located on the patient. The kinematic method requires a more elaborate equipment and the technique involved is more time consuming. The advantage of using a kinematic face bow appears to be more theoretical than it is real. The first thing that we do while using a kinematic face bow is mark 13 mm from the external auditory meatus on a line from the outer canthus to the superior border of the tragus of the ear. Then we place the patient in a semi-supine position with the head rest tilted back. Then we guide the patient to make hinge movements and we locate the rotational centers. We secure the stylus as shown in the picture and seat the patient erect with an unsupported head so that the stylus moves on the side of the face and makes a mark using a die on the graph sheet that is present. So the latest development in the field of dentistry in face bow is digital face bow. As the picture shows, the digital face bow decides on 3 points for tripoding in the natural dentition, and then the same thing is transferred onto a virtual articulator as shown in the picture. These 3 points are used to locate the plane of the natural dentition, and intraoral digital impression is made, which is transferred on to the software so that the digital cast can also be replicated or on the same plane as it is present in the mouth. So I would like to conclude by adding the advantages of FACEBOW as listed by Lazari. Firstly, it permits a more accurate use of lateral rotational points for arrangement of the teeth. Second, it aids in securing the anteroposterior positioning of the cast with relation to the condyle of the mandible. Next, it registers the horizontal relationship of the cast quite accurately and thus assists in correctly locating the incisal plane. Lastly, it is an aid in vertical positioning of the cast on the articulator. Regardless of the movement that the dental articulator is capable of replicating, the models must be positioned using a FACEBOW so as to allow us to replicate the position of the maxilla, which is necessary to allow the articulator to subsequently perform the correct movements. Blind orientation of maxillary cast on the articulator may result in errors, so slight that the FACEBOW transfer may appear unnecessary in complete denture fabrication. But since the procedure is not complicated or time consuming when using an arbitrary FACEBOW, the chances of minimizing error must be reduced. By mounting the maxillary cast to the same relationship that is in the patient will result in an opening and closing movement recorded on the mid-sagittal plane that can be duplicated in an articulator using a FACEBOW, hence it must be used. I would like to thank you all for taking your time out for listening to the class today. Thank you.